Okay, so the slides I'm recording are going to be available to you. I'll send that out in the follow-up email. I sent out some of the training materials that I referenced beforehand, and I'll probably send those out again just to make sure any late people who were registering didn't get the pre-email. And then also Portland State University is doing our evaluation of our initiative. So I'll be sending out a post-training evaluation that I would love for you to fill out. And if you want a certificate of attendance, that's how you can get it. Okay, so I am a part of the Older Adult Behavioral Health Initiative. It is based in Oregon, and it was created in 2015 and funded by the Oregon Health Authority. And we are 24 specialists that are assigned to one or more counties across the state of Oregon, and we're co-located within community mental health organizations or our area agencies on aging. And we actually have a few specialists joining us tonight, which is exciting. So we were created to address the unique needs of older adults and adults with physical disabilities who are experiencing behavioral health needs. And we specialize in doing collaborations and coordinations within our systems of care. We help build knowledge capacity through workforce developments, but then also community education. So tonight is kind of a mix between the two of those. A lot of folks are here who identify within the LGBTQ+ community, but there's also allies and support people that want to understand how to better support people with advanced care planning. And then we also provide complex care consultations. So if you want to learn more about the initiative, you can go to oregonbhi.org, and that will give you a lot of other things. Okay, so I'm in Josephine County in southwestern Oregon. This is my contact info for anyone for future reference. My background is as a death midwife. And so I've spent a number of years supporting people at end of life and doing advanced care planning. I identify myself within the LGBTQ community, although I've ended up living a cis heteronormative marriage. And so, but this is something that I have a lot of passion about, and I have a 19-year-old trans son and many friends that I am working with and have had a lot of experience supporting people in really great ways, and then also supporting people in very hard ways when we're navigating next of kin versus chosen family, and we'll get into that a little bit later on. So that's where I'm coming from in providing this workshop. Okay, so we're going to get into the advanced care planning aspect. So what is advanced care planning? I feel that advanced care planning is more than just the forms and the documents. And we really look at it in three different ways. So we have the forms and the documents, but we also have this need to explore what matters most to us, to be able to make those informed decisions and to understand what our preferences are and could be. It also, a very big part of it is having those conversations with our appointed decision makers, with our families of choice, and our support folk. And so that can look like healthcare providers, that can look like home health providers, behavioral health supports, any of the more professional realm, and then also those informal caregivers and support people in our lives. And so really all three of these things that are under the advanced care planning really are something that can move us towards that sovereignty and self-determination and self-protection that is really important for people within the LGBT community because of the history of oppression and discrimination, and really having to function within a system that does not include the diversity that we are made up of. So the reason why advanced care planning is important is because it does provide the support and the pathways for us to know how to honor one's end-of-life wishes. It helps create person-centered decision-making, and it normalizes the concept of planning. The idea of having these plans being, made ahead of time sometimes feel it's morbid, and people stray away from it. So we really want people to normalize it so that it happens more often and it doesn't wait until the very crisis moments. It's also important to help identify goals, values for any of our future healthcare and death care decisions. And that's one of the things that's a little unique about the advanced care planning that I promote and get out there, is that I also include that death care aspect of it. There's a lot of different legal forms that we'll go into that include it, but only very few states include death care alongside the healthcare directives. So the reason why advanced care planning is important for LGBTQ plus folks is because we're more likely to experience health disparities. There's an increased likelihood of encountering discrimination, homophobia, transphobia in healthcare and aging services. And in Oregon, we actually had a LGBTQ plus older adult survey that took place, and we had over 1,000 older adults actually participate in the survey. And it was very reflective of the demographics of Oregon. So it showed that nearly 60% of Oregon's LGBTQ older adults reported experiencing discrimination, transphobia, homophobia in their healthcare settings. So it's a real issue. We also know that our personal, family, and social acceptance of our sexual orientation and gender expression really does affect our mental health and personal feelings of personal safety. And so to be able to address that and to be able to create those specifications is really important. And that leads into helping define who family is and who we trust to make decisions on our behalf. And then also many caregivers are not related by blood or marriage. And so a lot of times our family of choice, the people that are our support system, oftentimes are not the ones that have any sort of legal standing. And so we really want to make sure that we create the opportunity to choose who are the people that we want and that we trust to make these decisions and to carry out our healthcare and death care plans. So one of a great resource we have is SAGE. SAGE is a national advocacy group for older adult LGBT plus folks. And they did a survey in 2014. So I imagine that the numbers are a little bit different now, but just to give you an idea. So 40% of older LGBT adults reported that their support networks are becoming smaller. 34% live alone. Up to 30% experience lower rates of access to care. 51% of LGBT older adults report being very concerned about having enough money to live on. And 40% say that their healthcare providers don't know their sexual orientation. And 23% did not see a doctor when they needed to, or seek medical care for fear of being mistreated. So that's that historic oppression and discrimination that people are experiencing within their healthcare providers. And not many people understand that self-disclosure is something that does not happen often. And so this is something to take into consideration when we are doing our advanced care planning, and especially people who are supporting others that identify within that community, is to understand the dynamic of self-disclosure, the fear around doing that, and the reasons behind it. You know, we do have these conversations about person-centered care, and a lot of places are pushing to have person-centered care, but that still doesn't open up the discussion and have people understand what it is like to be someone within the LGBTQ plus community when they're seeking gender affirming care, or you know, working with any of their healthcare providers and feeling that they may not receive the same level of care if they disclose. So I've been talking about a lot about older adults, but I also, you know, this is for adults of all ages across the lifespan, because we know that there's certain things like sudden events, car accidents, or illnesses that can make us not able to make our own decisions. So we still need to have a close person, you know, appointed to make those decisions when we can't make them. So this is for anyone 18 years and older can participate in advanced care planning. We also want to look at unexpected death, and to make sure that one's gender identity and expression are respected and affirmed after death. And that is, you know, looking at the funeral homes and providing that that community of care that the LGBT community is so amazing at doing for ourselves, and really providing things outside of the mainstream systems of care around funerals and after death arrangements. So we want to consider, so more than 90% of people think it's important to talk about their loved ones and their own wishes for end-of-life care. But only less than 30% of people in the United States and Canada, I believe this was both the United States and Canada, have discussed what they or their family wants when they come to end-of-life care. So yeah, so I wanted to open it up for anyone who, how many of us here have, you know, completed an advanced directive, or have had a specific conversation surrounding either your healthcare preferences or your death care preferences. So in the chat, if you just want to put yes or no or advance, whatever you want to put, it would be great to just see where we're at. It looks like a lot of people have participated, so that's great. So the next thing that I have down here is that in that older adult LGBTQ survey in Oregon, 42% of folks said that they had advanced directives in place. And that's, I mean, that's a really great number, but I am wondering how many of them have had conversations and how many of them have thought about what it takes sometimes to put those measures in place. And so that number is exciting for me, but it also leaves me, I want to do surveys that are more detailed. Okay. So we're going to move now into talking about what is the forms of advanced care planning, because this is a really good thing to understand. And whether you are an older adult who is going to be thinking about these things, or if you're someone who's going to be supporting an older adult, it's good to know what these different forms are. And we'll learn what each of them. So the first two that we're going to look at is the advanced directive and then also the POLST. And so the advanced directive is sometimes known as a medical power of attorney. And there's a lot of different names for it, and it can get really confusing because every state calls, you know, a medical power of attorney, an advanced directive. Some people call it a living will, and it gets really confusing because they all really mean the same thing. But when we look at a medical power of attorney, it breaks it down to that is simply appointing a person to make your decisions. When we have a living will, that's when we can kind of create more of a narrative and a story around what are the things that that we see as important. So things like talking about our spiritual ideas or talking about the reasoning why we decide certain things. And so in Oregon, we have a really great advanced directive that includes both of those. So not every state has, you know, open-ended questions asking you to explore your beliefs, but some states do. So I'm happy to say that Oregon, we have a pretty good advanced directive, and we have the ability to authorize a healthcare representative to make our healthcare decisions for us when we become incapacitated. And so that incapacity can be either cognitively, being, you know, a doctor saying that we don't have the capacity to make decisions for ourselves, or incapacitated as in we are unconscious and we are not able to communicate. The second form we're going to look at is the POLST. And so in Oregon and a lot of states, they are brightly colored. And so in Oregon, the edges of it are pink. You can see in this picture here. And this stands for Portable Orders for Life-Sustaining Treatment. And this is a form that turns our advanced directives basically into a medical order. And so this is something that only a doctor, a nurse practitioner, a physician's assistant, or a naturopathic doctor can sign. So this is a medical order. The advanced directive is a legal document. And we'll go into a little bit explaining the difference between the two. So an advanced directive is a legal document. A POLST is a medical order. An advanced directive is anyone who's 18 years or older, but a POLST will only be signed by a doctor if you have a serious illness or advanced frailty. So it is not unlikely that you would have a medical event that would make your heart stop beating. And it needs to be signed by the medical provider. An advance directive, the way to do that in the state of Oregon is that it can be witnessed by 2 people, or it can be notarized. So that is pretty amazing. You don't have to go anywhere as long as you have 2 witnesses that sign off saying that you were in your right state of mind when you filled it out. And as long as they are not your decision makers. So you can't have your decision makers witness your advance directive. So the next 2 things that we're going to talk about will also show more of the difference between these 2 forms. So an advance directive is something that is a legal document that's utilized by hospitals. It gives guidelines to our decision makers on what we want for different scenarios at end of life. The POLST is something that is really only used by paramedics and first responders and at the emergency department. And so this is the only thing that would, if you chose to not receive CPR or any life-sustaining treatment measures, this is the only thing that would keep a paramedic from performing those things on you. So even if you have an advance directive that says, I do not want to receive CPR, it doesn't matter. You have to have a POLST. It's the only thing that would keep a paramedic outside of the hospital from giving you those life-sustaining measures. So if you're someone that wants every possible intervention, you don't really have to worry about a POLST because they will do everything possible. The POLST really is for most utilized by people who want to make sure that they have their wishes honored, that do not want to receive all of the life-sustaining measures. And we'll go into what those different areas are. The last thing before we move on to understand is that these forms, both of these forms, are only valid in the state that they originate from. So we have communities that kind of are on the border of different states, and you may have to go to another state to get medical care. And you're going to have to make sure that these forms are filled out for each of those states, because hospitals can honor them, but a lot of times they will choose not to because they want to protect themselves from liability reasons. So if you are a snowbird like my grandparents, or if you're a person who lives, part-time in one state and part-time in then another state, you need to make sure that each of those states are covered. And especially if you are someone who has a serious illness, and if you're going to be traveling. Okay, I'm going to take a moment and answer any questions that people have, because this is one of the areas that a lot of people have. This is a different understanding that they thought. So I will open it up for anyone that has any questions, if you need clarification or anything of that sort. And you can just unmute yourself. You don't have to put it in the chat.
Hey, Angela, it's Liz. Glad to be here, by the way. And I did drop this in chat. I actually helped family member arrange to get a POLST put in place, and had the, in this case, it was a nurse practitioner, not understand the difference. And so I just thought it worth sharing. she was convinced an advance directive would be honored by EMS paramedics, and that is not the case. So I think it's important to really emphasize that and not be afraid to clarify that, if you're helping somebody or you need a pulse, to make sure that you understand that is the only document that EMS and paramedics, and it's really important. If you're somebody that doesn't want to be resuscitated, and you have that, if you don't have that in a pulse, EMS and paramedics will try to resuscitate you. So I just wanted to make that mention. I was actually kind of surprised to have that pushback from a provider.
Yeah, thank you for that story. And unfortunately, not all of our medical providers have a lot of clarity around these documents. I've had some experience as well with folks in hospitals and having to kind of educate providers on why someone would want to POLST, and so it's good for us to have this understanding ourselves and to make sure that we have community education campaigns as well. So in the chat, we have someone that says, I've heard that some people get DNR tattoos. That sounds like it would not necessarily be effective. DNR tattoos would not be effective. Tattoos are permanent, but our wishes are not necessarily. So yeah, a DNR tattoo would not be considered a legally binding anything. So, and then we also have, is there an out-of-hospital DNR form for someone not at the end of life who still desires no CPR? So this is different for every state, but I know that in Arizona, in Oregon, that a DNR is hospital specific. So anyone can get a DNR filled out for that specific hospital stay and say that they do not want to be resuscitated at any point in their, because we can always refuse medical care. The reason why the POLST was created is because they want it to be portable, so that if someone went to one hospital and they then had to be transferred to a specialist or transferred to another hospital for care, they had no way of making sure that that DNR could follow them throughout their entire care. So that's why it's called the portable measures. And so in Oregon, each hospital you could do a DNR at, but the POLST form will only be signed by the doctor if you are advanced illness or frail. Okay, so POLST forms, DJ, I'm not sure if you're in Oregon or not, but in Oregon we have a registry, and so the doctors submit your POLST to the registry, and that way the first responders are able and trained to check that before they attempt life-sustaining measures on anyone. And then also there are wallet cards and different things that you can do to help let them know that you have specific instructions with a POLST. Okay, so we are gonna move on.
Angela, if you don't mind,
yeah, Jim, I just saw your message. So what is your comment?
Well, hello, everybody. Hello, Liz. I'd just like to mention one thing, as it is unique. I don't know if it's entirely unique, but probably more prevalent among HIV/AIDS long-term survivors. That is the population who are my friends and social circle, and also are the people that I work with. They're far more likely to live alone. They are far more likely to not have a partner, to be widowed, to have outlived their family, to have had their entire social circle die. Many of them are just utterly, entirely alone. And that's a really big part of the Aging Well program is to develop community for them and to find how we can establish social circles. But still, as this conversation proceeds tonight, it'd be really great if we could note, particularly when we're talking about instructions for your caregiver or for your family or for your family of choice or what. There are people that I work with have none of that.
Mhm.
And my own estate attorney has set up, and by the way, I'm in that circumstance. My estate attorney has set up a fiduciary for me. So there's a third party professional who's going to handle all that stuff. But it's certainly not going to have the personal touch of having a family of choice work with it. But I've always wondered what happens when somebody does not have these documents and these systems in place, and they die, and they don't have a family, and they don't have a social circle, and they don't have a community. What is the default? Well, something still happens.
Yeah.
What is it that happens? And what about people who cannot afford the acquiring the services of a fiduciary like I have?
Yeah, so we'll go into that. And if I don't answer that by the end, please pop in and ask me again.
Thank you.
Because, yeah, I definitely want to touch on that later on. Yeah, thank you, Jim. Okay, so we are going to look how advanced care planning can look different as illness progresses and as our goals and values change as we age. And so there's really three different levels that we look at. We have the first level is just adults who have not started or engaged in any advanced care planning. So people who are brand new. We have the second where adults with serious illness who have a potential for complications. So folks that are living with chronic illness. And then the last level is that we have frail older adults or those who death in the next 12 months would not be unexpected. So we are going to kind of cover a little bit of each of these today. So one of the big parts when looking at advanced care planning on any level is exploration. And this is one of the most important aspects. And we're going to go over kind of what are the things that we can explore with people. And so the first thing that we can explore for ourselves and with the people that we support are to identify our fears and concerns. Looking at what our experiences have been and what are the things that we want to make sure that we are protected against any of the concerns. We also want to have the exploration in our conversations with people of their understanding of what an advance directive is or what a POLST is. We want to make sure that we also have a good grasp. We want to explore what conversations we've had with our healthcare providers, with our decision makers, with our family, with our partners. And we want to explore our understanding of our medical condition, to understand how that is going to affect some of the interventions that we might be wanting, and then also to look at our hopes in living well and what that means for us. And so oftentimes we want to think about what are the things that bring us joy? What are the things that we want to keep doing as long as we possibly can, so that we can have our decision makers kind of base their decisions on some of those parameters. We want to look at past hospital and serious illness experiences to figure out like what did we learn from them for ourselves or family members or people that we love. What did that look like? What are the positive things? What are the negative things? To really understand where our choices are coming from. Are they coming out of a place of fear? Are they coming out of a place of wanting to create a better situation or a better understanding for the people around us? And then we also want to explore our cultural and spiritual beliefs and how they relate to the way that we want our care provided, but also we need to understand that certain people will make decisions based on certain cultural and spiritual factors. And so when we're supporting someone, we need to honor that and understand that people have their own culture. So the way that we make decisions might include more than just that one person. If we have someone who is in a poly relationship, that it's not someone who's just going to be looking towards a partner, one partner, it could be multiple. Also just family dynamics of, you know, certain people may go to someone to help them make those decisions. So we need to understand those dynamics, and then also the spiritual beliefs of sometimes are the foundation of how we move through life. So understanding that. So this next part is thinking about our goals of care for ourselves and for other folks. And there's two different groups that we're going to look at. The first group is for people of all ages, for all health conditions. We really do need to understand and make an informed decision about things like CPR and life-sustaining treatments. And so it is good to understand the success rate of CPR. It's good to understand how that changes when we receive CPR outside of a hospital, and that if we receive CPR outside of the hospital by a medical professional, we will always be transferred to a hospital. We also want to make sure that we have the conversations with our care providers and asking them to really give us a clear understanding of, like, based on my personal health, what are my chances of success if CPR were to be applied to me? We have this this notion when we think about you know, Grey's Anatomy and ER and movies, and we have this idea that anyone can receive CPR, anyone can receive these life-sustaining measures, and we're going to survive. And we're going to get unintubated, and we're going to be talking, and we're going to be going home and being jolly. In one of my trainings that I took to become an advanced care planning instructor, one of the women that was with me did a study and figured out in all of the Grey's Anatomy episodes that they said, I think she said 68% of all people who received CPR survived and lived healthy, long lives. And so some of the data that I'll share with you, and this is not to sway anyone one way or another, this is just providing information so that people can be informed. And so of those adults who receive CPR in a hospital and live, and these are adults of all health conditions. So this is of all adults, 26% will leave the hospital alive after receiving CPR. For those adults who are older, weak, living in a nursing facility, and CPR is successful, 2% of all individuals. So 2 out of 100 older adults in a facility, it's successful. So we need to understand what outcomes we would expect if CPR was started on us in our current health condition, and have that conversation with our healthcare providers, and just understand what results we might expect. So the next thing that I want to look at is for anyone of all ages, all health conditions, is to understand what our goals of care would be if we had severe permanent brain injury. So having that accident that caused us to be in a coma, and understanding what is the percentage, what is the chance of us surviving this, and just to think about it. And it's really hard to think about this because it's such a drastic thing, but to really have the conversations and to figure and think about it. Would I want certain measures taken? How long would I want them to be tried out before anything would change? The next area that we're going to look at is folks who have the serious illness, folks who have a life-limiting illness. So this is when that POLST really comes into play. And there in the POLST, there's a section that talks about different treatment options. And so what we want to make sure is that our priorities for medical care align with our treatment options. And so on this slide, you'll see the different types of priorities for medical care. We have 3 different options. We want to live longer. The middle one is we want to be able to maintain our current health, but maybe that doesn't mean that we're going to be living as long as possible, no matter what. And then the third priority is comfort measures. And then those align with our different treatment options. So in the Oregon, we have full treatment. We have selective treatment, which means that you would not be intubated, have a breathing tube, but you would still get certain intervention measures like IVs and antibiotics, and some of the less invasive measures, and then also comfort focused. So that's when folks are going to allow a natural death to occur and not do these interventions. And no matter what people choose, emotional and spiritual care is always a component of all 3 of these different options. And we want to think about the things that if we want to stay home, if we do not want to be in a hospital, if we want to be able to have a trial of different treatments, we're going to have to figure out where those align with the different choices on the POLST medical form. Okay. So the next thing that we're going to look at is choosing a healthcare agent or decision maker. And this might answer a little bit of what Jim was asking before. So our healthcare agent should be willing to, 1, accept the role, 2, talk with you about goals, values, and preferences, 3, follow your decisions even if they do not agree with them, and 4, advocate on your behalf, and 5, make decisions in difficult moments. So not a lot of people, when they initially think about this, they think about their closest person. They think about their partner. They think about maybe a family member. And that's not necessarily the person who's going to be the best fit for this. So you want to be able to have someone who's going to be able to advocate on your behalf during these times of kind of emotional stress, and someone who's going to be able to advocate not only with your healthcare providers, but also advocate within your support network. You know, sometimes things can get a little bit messy. So someone that needs to be able to communicate the reasoning of why you've chosen these things. And then at the very bottom, I did put that it may be better to not appoint a certain decision maker if they're not comfortable with your wishes, or someone who does not respect your gender identity or expression, because written preferences documented in advance directives are supposed to be followed even without a representative. So for someone who doesn't have a support, support circle around them, who doesn't have a decision maker that they can think of, it is good to write down your preferences and have your advance directive filled out. You don't have to assign a decision maker. You can just fill it out and put down what you want and write down a narrative of all of the different exploratory things that we talked about. And then you can also, there are different organizations that can provide, kind of like a volunteer decision maker. I am not aware of any in Oregon specifically at this time. So if anyone else knows, I would love to know. But there are organizations that train people to be volunteer decision makers for folks that do not have someone for them. And so this is a process where, there's a lot of training and trust that goes into it. Thinking kind of like with guardianship. Someone who is appointed a guardian, they need to make sure that that guardian is going to, honor and respect their wishes. So this might be something, Liz, Jim, that, we could think about, like, can we create, a group of people who will commit to being people's people, and so that's something to consider. So if your decision maker is not next of kin or your family of origin, we need to make sure that your appointed person informs your next of kin that they're your decision maker and that they get the copy of your advance directive. And so this can help kind of clarify things, untangle a little bit of mess, because some people are going to come in thinking that they have the legal right to make these decisions for you. But if you are estranged from that family member, or if you do not see eye to eye with them, you need to let them know ahead of time they're not the person who's going to be making these decisions. So it's just good to make sure that we inform our legal next of kin when possible, who our appointed decision makers are, and even have the conversation with them if you feel comfortable enough to why your what your goals, values, and preferences are. And it's good to make sure that your appointed healthcare agents also have HIPAA authorization. So different hospitals can have a form that you can appoint them so that they can, that people can talk to them about your medical records, and there's no question at all. So when we look at trans and gender expansive specific additions to advanced directives, we talked about the narrative section that you can add to your advanced directive specific instructions. So these are some things that the Transgender Law Center has given sample language, just to give you some ideas. So, stating, I direct medical staff should respect my identity as a transgender woman by only using the pronouns she, her, hers when referring to me, ensuring that when gendered attire is available, I am dressed in women's clothing. Because when we cannot communicate for ourselves and we get taken to the hospital, those doctors and those nurses are going to assume based on their visual input. And so if you are a trans or gender expansive person, you need to make sure that they know in your advanced directive what your preferences are and how they can respect your identity. The second one, I direct my decision maker to speak to hospital staff and ensure that whatever name is your chosen name is used when referring to me in accordance with my non-binary gender. So people who haven't legally changed their name, they can still ask that the hospital staff utilize their chosen name when referring to them. And then the third one, example, I direct medical staff to continue with my regimen of hormone therapy as long as it does not seriously interfere with any other necessary medical care. So this is something that's really important to a lot of trans folks that are utilizing hormone treatment. Okay, so I always want to add dementia into advanced care planning. So there are addendums that you can add to your advanced directive, and I actually sent it out in the email, an example of one. And so dementia is one of the most common reasons people lose the ability to guide their own care. And LGBTQ folks are at higher risk for dementia. The Alzheimer's Association has an amazing they're doing amazing work, and they've done a lot of different surveys, and they're continuing to do studies. And so a lot of the information that I have is based off of the work that they've provided. So there is no cure for dementia. People gradually lose the ability to speak, eat, and walk. And this process can take anywhere from 5 to 20 years. So we want to think about what we would want when we still have our capacity, because when people are in advanced dementia, it's going to be really hard to sometimes have clarity on what the preferences are. Okay. So advanced directives and is what we're looking at right now. And we're going to talk about who gets a copy of that. So we want to make sure that we keep the original and that we give our appointed decision makers a copy. In Oregon, you can appoint up to 3 people. You have your primary, and then you have alternatives. So you want to make sure that each of them has a copy. You want to make sure that your primary care physician has a copy of it. And then you also want to make sure that if you were to be taken in an ambulance, what hospital would you be taken to? You want to make sure that that hospital has it in their medical records. If you needed to be life flighted somewhere, is that a different hospital? So you need to make sure that that hospital has a copy of your advanced directive. Before I was in my position, I thought that all healthcare systems just shared information, and it was like, really easy to get it. And it's not that way at all. So you need to make sure that all of the different healthcare systems that you are going to could be a part of have a copy of your advance directive, or your decision maker has it accessible and can provide it, you know, when they are asked. So the original should be stored with other important documents, and it should not be put in a safe. It should not be put in a locked cabinet. It should not be put in a safe deposit box. And because oftentimes when someone gets in the situation where they need it, we don't know how to get access to it. So one of the tricks that I was taught is to utilize a waterproof plastic like folder case, and put all of your important documents in there, and then put it in your freezer, because it's the one place that would survive fire. It's the one place that people who maybe are looking to steal your identity are not going to look in your freezer for important documents. But it's a place that you can keep those original copies. And it's always good to keep electronic versions on hand and paper versions. So I am going to look at the chat. Yes, making sure both in paper and electronically. And someone mentioned about the cell phone. So for iPhones and Androids, definitely iPhones, there is a health app that is automatically a part of your iPhone. And so you can put in who your decision maker is and notes about having an advance directive in there. And emergency responders are more and more trained to actually be able to access that. So they can access the emergency contact and those notes without needing your passcode. So there's a certain way that they can get that specific app information. So it's things to consider. Okay. So are there any questions surrounding healthcare, the healthcare aspect of advanced care planning before we move on to our after death care section?
Question that's sort of related. We
Yeah.
used to be, yeah, this is Joan Marie. We used to be able to get printed copies from, oh gosh, I don't remember, but they were the nice blue ones that had pretty pictures on them and whatnot to give to people. And
You're talking about in Oregon?
I'm sorry, in Oregon.
Yeah. That
Is there-
organization, I think I'm going to say went under. That's probably not the best term, but they stopped existing during COVID. And so that is not available anymore unless someone has bulk amounts hidden away in their office, which is happening. But is there another question, Joan?
No, I was just hoping yeah, that is unfortunate. Thank you.
Angela,
yes.
Lillian here. I live rurally, sort of in Roseburg, Oregon, and the chances of something seriously happening and being flown out of here are kind of high, but we don't know whether that could be to Portland, the OHS, to Eugene. So are you recommending we just go ahead and send to 3 or 4 different hospitals for that possibility?
You could. I don't think it would hurt, to send it out, at least to, so if you're in Roseburg, I mean, I would ask your healthcare provider and ask them, what are the hospitals that I would most likely be,
Well,
transfer to.
we know as seniors from what happens to other seniors,
Yeah,
and often it, happens right out of the ER, if they can't handle it or intensive care. And it's whatever hospital, they decide that would happen for. Along with that question, is there a time limit on how long, if I were to send out today, I'm 81 and I'm fine till I'm, 90, would I need to periodically resend,
Yeah.
to those hospitals?
So the advanced directive is for your life. So you can do it once and it'll always be in place until you change it. You can change it at any time. You just need to send out new copies and say, destroy the last one. This is the new one. So that will always be in place. The POLST, really every 5 years, if it hasn't been utilized in 5 years, they want you to fill out another one. And that comes directly from the POLST registry folks. I did not realize that, but they said that typically they like it every 5 years. And I think that's just to make sure that your health condition, 5 years is a long time to live with certain life-limiting illnesses. Does that answer your question?
Yes, thank you.
Okay. Any other folks before we move on to the after death care? Okay. And I'm trying to find the app. It's just called Health. And under the Health app, there are health details that you can type in, different things, and then medical ID. And under the medical ID, there's other questions that you can fill in. And so the medical ID is what anyone can access that has the knowledge to access it. And all the first responders know how to do that. Okay. Okay, so I am going to actually, if people want like a 5-minute little bio bathroom break, because we're just a little over an hour, I want to give people the opportunity to run or walk to the bathroom, or get a drink of water or anything like that. So let's start back up again at 6:15. So that's going to give us 5 minutes. Yeah. So I'm going to run out myself. Okay, so we're gonna start back up again. And start looking at after death care directives and how to ensure our after death care rights. So why is this important? Well, completing an advanced after death care directive, even though it's not a legal document, it can still guide and support our family and friends about what our after death care wishes are. And I sent out one that I created that can be utilized. And there are other organizations that create really beautiful crafted like booklets that are binded, and it's really great. So there's like a spectrum of different advanced or after death care directives that you can utilize. And a lot of it, we want to put down the gathered required information that we need when it comes to death certificates. We want to be able to put down what our final arrangement wishes are, what the different disposition preferences and instructions, and then obituary or any written communications. So it's really just like an advanced directive. It can give instructions and kind of a guideline, and also it can give you a chance to kind of appoint different people to maybe be the people responsible for helping carry out your plans. So I recently discovered a great resource, a woman, her name is Zena Sharman, and she writes a lot about queering death. So I just wanted to put this out there, that when we talk about the LGBTQ plus community, a lot of times we are talking about creativity. We're talking about a history and community of collective care, of self-determination, of resisting oppression. And so there is a culture around, like I said before, making something that is not typically reflective of what we look like and what we experience our lives. And so to be able to reclaim some of that work that we hand off to other professionals that are not necessarily affirming of our identities or even understanding of anything within the LGBTQ plus community. And I really like this quote of, "Can we dream ways of not only of tolerance and accommodations, but truly dying authentic deaths as we live authentic lives?" And the pictures here are some examples that she talks about. We have different living funerals. We have on the left here, we have this person known as Glam Drew, and they did a living funeral and almost a performance piece to bring people that he loved into his deathbed, and created ritual and community and ceremony, just days before his death. And so he reclaimed that space. And then we also have, this is Mitzi, or Shotzi Weisberger, and she was a death advocate, and when she was, I believe, 88 years old, she had a living funeral party and had all of her friends come through, and the picture below is of them painting her cardboard casket and had a party. And so she did that, I think she lived for another 4 years after she did that. So these are all things that we can do to, help reclaim this end of life and this death space and do it our way, and be able to help support other folks to really reclaim this space. So again, the same thing when we talk about exploring before death, we want to do those same things to exploring our after death care. So we want to look at our fears and concerns. We want to look at our past experiences with death and funerals. We want to be able to understand what is causing us to want to avoid certain things or to do certain things. We want to look at what conversations we've had with people. We want to understand all of the different final disposition options. And in Oregon, we have a lot, and I'll go over all of the different possibilities in Oregon. We want to look at hopes and possibilities, and to use this as a time to really be creative and to be able to live and be honored, or not live, but to die and be honored in the way that we lived. So we can reflect our values in our after death care rights and wishes. We want to be able to look at different cultural and spiritual beliefs, to be able to integrate those into our ceremonies and into any of the things surrounding our funerary or after death care work. And then we want to look at what support and services are available, because we want to be able to make sure that we have the team who is willing, ready, and able to make it happen. And so that's when people, we need to have that support and that see what services are available in our area to make it happen. So when we look at final arrangements, we have different options. We have the use of a funeral home. We have the option to have a home funeral. We can have a funeral elsewhere, and we can have no funeral at all. And so in Oregon and almost every state in the United States, it is possible to do these things within our family of choice, within our support systems, and that we can utilize the funeral industry when we want, but we don't have to necessarily use them if we want to do it ourselves or make it a collaboration. So in Oregon, we can do basically every single final disposition there is, except one or two. So we have cremation, we have alkaline hydrolysis, which is also known as aquamation, and that's when the body is broken down in a vessel with warm water and vibration and lye. And just like cremation, it reduces down to bones, which then they can pulverize and return the bones. So you still get some remains that you can utilize. This is something that has been utilized within the veterinarian community on a regular basis, but it hasn't really been extended to us as much, but it's becoming more and more available. We have natural reduction, that is also known as the human composting, and that is when there's a facility that started it, kind of one of the first places to do it up in Seattle, called Recompose, where you are basically put into a vessel that has sawdust and different organic material in it. And over time, I think it takes usually about 90 days for the process to complete. Then what you have is soil remains. And so you can either get a small portion of that and donate the rest to be utilized in tree replanting, or you can take the whole lot and use that for what you want with your own garden or, you know, trees. So that is an option in Oregon, in Washington, Colorado, Vermont, and there might be 1 or 2 other states that also have legalized it. But you can always transfer someone to a state that is legal and have it done. So don't think if someone you know is outside of those legal states that they can't have it happen. It costs more money to transport them. We have body, organ, and tissue donation. This is always a possibility, and you really need to do your research when it comes to this. Not every tissue organ donation goes towards what you would think would be saving a life. Sometimes it is sold to different corporations that create beauty products, plastic surgery, you know, different things. So there's also, you know, research studies, and so it's something that you have to really look into and understand what you are donating your body to, and make sure that is specifically for what you want to go to. The next thing is we have the conventional lawn burial. We have green and natural burial, which means that there's no embalming, and you are only buried with biodegradable shroud or a casket. And this can happen in the newer cemeteries, and any of the old cemeteries. That's what all of the older burials have been, were natural green burials, because we didn't really start embalming folks until after the Civil War, and so it didn't become a something that right now a good chunk of people get cremated and a good chunk get embalmed, but that wasn't always how it was in the United States. Home burials, certain counties, it goes county by county really in Oregon on whether or not you can have a home burial or what the requirements are. Not every state can you do a home burial. Like in California, you have to have a private cemetery to be able to bury someone on your home, and that process can be very costly. So you just have to do your due diligence and research whether or not you can do home burials. Burial at sea, even if you're not a military person, that is a possibility. And then the military burial as well. Okay, so one of the ways that we can maintain our after-death care rights and make sure that we protect ourselves and make sure that our family of choice are the people who are going to be able to do our final disposition arrangements. And so that means final disposition is what you're going to do with your body after you die. And so you can appoint a person to make the decisions concerning the disposition of your remains. And this form, it's stated differently in different states, but almost every state has a form where you can appoint someone that will make it that your legal next of kin is not the person who's going to be making these decisions. And so again, this is really important for the LGBTQ community when our legal next of kin is not always the people that we want to be in charge of our bodies after we die. And legal next of kin, this is the line. So legally, the very first people that they go to when you do not have any documentation, and this will answer a little bit of your question, Jim, is that they will look to see if you have a spouse or domestic partner. If you do not have a spouse or domestic partner, the next people that they go to are your adult children. If someone doesn't have adult children, then it goes to your parents. If you don't have any parents that are living, it goes to your siblings. So if you have a brother or sister that's still alive, they're the ones who are going to be able to make decisions for you. Then it goes to your grandparents, then to your aunts and uncles, and then to your cousins. So this is the line. You have to go all the way through this before they'll even consider listening to a person who is a close friend. And so if there is no one and you die and you don't have any money, the state will pay for your cremation. And in our county, each of the funeral homes has a 3-month rotation. So for 3 months, one funeral home will get all of the, they call it indigent burial, like cremations. And so they will do it, they provide the services, and then they intern the cremains in a specific area. And then next 3 months will be another funeral home. So that way they carry, they rotate the duties amongst the funeral homes and the county. So you don't, some people are, they say that they go to the dump, but that's not what they do. They intern them in different areas, different funeral places. And so that is kind of the default. So if you don't have anyone and you don't have anything set up, the state will pay for you to get cremated and will, in an unmarked area. So that's kind of how that goes. So some of the things for trans and gender expansive folks for after death care considerations. So this is kind of a checklist of things that we want to be able to think about for ourselves and for the people that we support. Liz, do you have a question?
Yeah, thank you. So just a question about having a legal document giving somebody the right to take care of your body as you wish after death. If somebody is a trustee or an executor, will those suffice even if you don't have a directive specific to your remains?
Yeah, so if you have a power of attorney and it gives you the authority to make financial decisions, so a financial power of attorney, that a funeral home will use that. So you can do that, but it has to be that is only before a death. So if you want to help do the arrangements financially with like a pre-arrangement, you can only use a power of attorney to do that. But after someone dies, this form will, be in place of that. So that's a little confusing, I think, of how I said that. But funeral homes will take a power of attorney form, if you have that, to be able to do the final arrangements. But the only will take the power of attorney before someone dies. Yeah. If you have to use, they'll they will let you do the disposition appointment after someone has died, because they can't, it's all financial. So a funeral home can't take money from someone that doesn't have the power of attorney before death. But
And
if you go ahead, Joan.
I'm sorry, if I may, I just explain it really simply to people. The power of
Good.
attorney dies when you do.
Good. Yes.
When
So
you're
power
dead, the power of
attorney.
attorney is dead.
Yeah. So power of attorney stops at death. So if you want to do any arrangements after someone dies, then you have to have that extra form that gives you the disposition assignment.
Yeah, well, and not to confuse things. So there's also when somebody dies, somebody becomes a trustee or an executor.
Yeah.
Would those suffice?
If it's stated in the instructions, then
Okay, got it.
Would be, yeah.
All right, thank you.
Yeah, you have to state it in the instructions. But I'm not a legal person, so any legal advice, you need to talk to a lawyer.
You're doing just fine.
Good. Okay, so when we're looking at trans and gender expansive folks, these are the things that we want to think about. We want to make sure that we appoint the final dispositions of remains agent. We want to make sure that we talk about our goals, values, and preferences. We want to talk about who are we comfortable with handling our bodies. And so we want to make sure that we make those choices. And if we do not want a funeral director being the one to handle our body and wash or dress us, that is totally fine. We can, set up our own group of supports to actually even go into a funeral home and utilize that space to prepare someone's body. Funeral homes are open to that. It's something that in Jewish religion, Baha'i religion, they make those accommodations to let people come in and utilize their space. So we can also ask for that for folks who do want to do that work themselves and still utilize a funeral home. We want to think about how our body is going to be shown. Do we want to have an open casket? Do we want a viewing? Do we want it to not? We want to think about how written communications are going to be handled. When we're talking about an obituary, are we going to be referencing past, dead names? Are we going to be acknowledging any sort of people? What are the pronouns and the different chosen family and different relationships that we want acknowledged in our communications after death? We want to make sure that we fill out that after death care directive, and we want to make sure that we find the support for the plan to make sure that we can have the follow through. And so this is something, for anyone, not just trans and gender expansive folks, but it's definitely something that I feel needs to be thought out for people who want to make sure that their gender identity expression is affirmed after death. So we're doing pretty good on time. So I want to talk a little bit about how do we start these conversations with folks. It always seems too soon until it's too late. So just to get them going. So some ideas is to ask a question. So what was it like for you when your loved one died, just to have that conversation. When our friend John died, do you think their wishes and priorities were respected towards the end of life? So having these, asking a question. The other thing is to tell your own story. So you could say, I was thinking about what happened when my mom died, and it made me realize. That's a good opening. Also, I just completed my advanced directive. I just went to this LGBTQ advanced care planning workshop, and it made me think this, also to ask for help. So I need information to help me know what you would like if you aren't able to talk for yourself. Will you help me with that? Or kind of flipping roles, even though I'm okay right now, I am worried that my health will change and I want to be prepared. So can we talk about some things that matter to me? Another way is to watch a movie together and ask natural questions afterwards. There's so many movies right now about death and grief and dying. I'm really amazed. Some great Netflix shows also. So as watching a movie together and just like, what's on your bucket list? What would you do if you had 1 year to live? So some of these kind of indirect ways to start these conversations. We have some great games. We have the Death Deck, which is a packet. I have it somewhere, but I don't have it at hand. A packet that has cards, and each one has a multiple choice question or a open-ended question. And so sometimes they're humorous, sometimes they're super serious. So it's just a good way to have a group of friends and hey, let's play a game and give it out to everyone, and everyone answers it. And so it's just a way, like an icebreaker game into having different conversations. We have events like Death Over Dinner, where we can invite a group of friends over for an awesome dinner party and have little conversation starter questions. And so everyone knows we're coming here and we're going to talk about death and dying, but we're going to eat awesome food and hang out with each other. So the first question is, what do you want to wear, after you die? Or what is your favorite song that you want to play at your funeral? Or what would you rather do? One of the funny ones, it was, what was it? What would you rather let people know that you died of choking on nachos? Or the other one was or that you got eaten by a shark in a swimming pool. I don't know, but they're just ridiculous things. So just that breaks the ice. It's kind of funny sometimes, and it's mixed in with some of the more serious things. There is the Hello game, which is kind of like the Death Deck. It has a lot of questions and it gives a framework to explore some of these areas. And then we have death cafes. Death cafes are group discussions that are about anything related to death and dying. It's not a support group. It's not counseling. It's just a safe space to talk about a taboo subject. They happen all over the world, and they are all over Oregon, all over the country. So there's probably a death cafe close by to you. And since COVID, a lot of them are offered online as well. So you can invite your people with you to attend a death cafe. One of the things that I really am wanting more folks to do is to participate in facilitated conversations. And so there are organizations that I've been trained through, and to provide these trainings to train facilitators that are able to sit down with a person and their decision makers and to really do that exploratory session, so that you don't have to be like, oh, I don't know where to start. But no, we have a guide and we can go through it step by step, and we can do this. And I would love to train LGBTQ plus advocacy groups, people within those groups and within the ally organizations, so that these conversations can be had outside of the healthcare setting, which people don't have time anymore to have these conversations. And we want to have it with people who understand our lived experience, or at least are open and you feel comfortable talking about your lived experience, to get those conversations. So we are coming to just a few more slides, and we are going to look at when to revisit your advanced care planning documents. So I say the 6 Ds. So the first D is decade. So every 10 years, you should revisit your advanced care planning documents. And that's from the time of 18-year-old. So when you are getting older, I would say once you reach 65, I would revisit them every 5 years, just so that you can align it to with your changing body and views and everything. 2 is divorce. So if there's any change in family structure in your love relationships or anything of that sort, you need to revisit it to make sure that your decision makers are reflective. Diagnosis. So anytime there's a new chronic illness or condition, you need to do that question again. We want to look at if there's any decline, and so that's in yourself or in your appointee or decision maker. So if you're seeing your decision maker maybe having signs of early onset dementia, then you need to think about changing to another person. Death, death of your appointee, or if there's an experience that you've gone through around death and it's changed your perspective. And then also distance. So if you move to a new state, like I said, you have to do a new document specific to that state. And then, as things change in our lives, we need to revisit and change our documents and our directives just as needed. So the other thing that I included in my email out to you was a checklist for a death file. And this can be in a folder, it can be a binder, it can be decorated, and so these are all the different things that we can include in our death file. And we want to put it somewhere in our home where people can find it easily when needed. And we definitely want to tell our death care support people where it can be found, and our decision makers. So we have our advanced directive, we have our death care directive, we have a will or a trust if we're going to be doing that, our durable power of attorney for finance, life insurance policy, bank account info, real estate documents, any pre-need documents for a funeral, any debtor information, a copy of our driver's license and social security card, copy of marriage, divorce certificate, letters and notes to loved ones. So these are all things that would be good to have in a death file, because this is information that the people are gonna need. So do them a favor and have it all in one place. Okay, so someone was asking for resources. And so these are some of the resources. We have the Oregon POLST. We have the Conversation Project, was a national advocacy and education group that talks about advanced care planning and how to have the conversations. They have amazing guides. We have Respecting Choices, which I am a trained instructor to teach advanced care planning facilitation. We actually have Rose joining us, who is also one of the instructors from Respecting Choices. They provide the ability to get trained. They provide different informational things. We have the OregonFuneral.org, which is an amazing resource for anyone in Oregon that is wanting to learn about home funerals, about all the different disposition choices, how to have a home burial. It's really awesome. It has so much resources. We have the Funeral Consumers Alliance, which is a great national advocacy group. And then we have the Home Funeral Alliance, which is a national group that helps people do resources of how to do things within our communities and in our own circles of care. And they talk about utilizing support from funeral homes or just doing it completely solo without any, sanctioned professional helpers. And almost every state in the country, you can do your own home funeral. Just sometimes you need a funeral director just to have oversight. So it doesn't even mean they have to like participate. They just have to have oversight and just kind of oversee things. Specific to LGBTQ resources, we have the LGBT Aging Center. We have Compassion and Choices. They have a great outreach toolkit. We have the Transgender Law Center, and we have, actually, this last link is no more. I'll have to change that, but this link used to go directly to our older adult LGBTQ survey that took place, but they had to rehome the survey. Okay, so the last thing before we have a few minutes to answer some questions is just really empowering ourselves and others to really create that agency and sovereignty at end of life and after death. So I want to open it up to folks to ask any questions. Go ahead, Jim.
Just was thinking that this is really random thought, so I don't even know where it fits in the conversation.
Yeah.
But I think it would be wonderful if there was some way that we could capture the history of death within our community. In the 1980s, there was a whole series of rituals of gay men who were dying of AIDS. And there was a whole entire everybody knew what a death party was, that you went to the party and that you knew that someone was in the bedroom. You went in and said hello and said goodbye and wished them well and had a toast and went out and met with the other people who were their friends are all gathered. And it was a rollicking, fun time. And very often people were invited to just whatever you see on any shelf in the house, help yourself, take it away. That's how my estate is going to be disposed of. Just help yourself. And there's a whole lot more to that, but it was a very significant, known, established ritual and ceremony. And I think I worry that that's going to get lost, that many of the people who participated in that are now gone.
Yeah.
You might want to check with the One Archives in Los Angeles. I think they've stored quite a bit of that. I was a part of the 70s and the 80s and actually lost my brother and a lot of other people in Los Angeles. And so I know that many people did send a lot of their information into the archives. And if they didn't catch it there, there's also, well, a lot of the archives is stored at USC, but also at UCLA. A lot of them left information to their alma mater in terms of their whole life history. But I would definitely check the archives.
Yeah. And
Thank you.
This is something that a lot of people want. A lot of people want to hear the stories of not only the, you know, the hard struggles, but like the resilience and the joy and the amazing things that happened. And so I think that's something that, you know, we can even put out there. You know, I would love to have a you know, a queer storytelling around death and dying, and just have people come and share their experience, you know, with a storytelling circle, and just document and pull out. I feel like this is becoming more and more on the surface. I'm one of 4 workshops this week specifically talking about LGBTQ end of life planning, which it's never happened before. So there's a lot of people who are like really wanting to reclaim the space and to make sure that the stories and the history are not forgotten. Yeah, you're connected with Liz James somehow?
Yes,
Yeah, so maybe we'll be in contact, and we
thank you. Thank you.
definitely. Lillian, did you have something else?
Yeah, I did want to share something else for those of us in Oregon. Probably most of you know it, but the very first gay hospice was started by Billy Russo here in Roseburg. And that man alone nurtured and nursed to their death so many gay people, men and women, and even children who were non-gay. A lot of, I believe, his work has been sent to the archives in Oregon. But he happens to be a close friend. So if you don't find it there, get in touch with me and I'll find out exactly and let you know back where he sent all that material. And I'd say, yay, let's do that kind of thing before we lose all those stories. And it would be great to get permission to, perhaps even record some of them and then pass them along in workshops where other people have access to some of that creativity, because there was certainly a lot of it. And I'm fortunate to have been a part of much of it. So I would love to see it pass along.
Yeah.
Angela, thank you. I'm afraid I need to say goodbye right now.
Yeah.
It's a wonderful group. And I sent you a chat. We did something similar to our Roseburg community through the Elderly Oregon Behavioral Health Group representative about 6 or 7 years ago, and had a lot of people from a lot of different communities come to our Unitarian church. And I would like to do that again, so maybe you and I can get in touch.
Definitely. Yeah.
I'll send you an email, and thank you.
Yeah. Thank you for attending. Thanks. Okay, we have a few more minutes. Does anyone else have any comments or any questions that they want to make?
But just Angela, I just want to leave you with gratitude of how helpful this is, and so much knowledge and actually great graphics. And there's so much resources here that is really going to be helpful for me. So I just want to say thank you.
Oh, you're welcome.
Angela, this is John Marie. Can you just stay on the line for a second after everyone else leaves?
Sure.
Thanks.
Okay, well, I'm gonna turn off our recording, and there we go.